narrows in the mouth. Now, forceps are important. The forceps, as opposed to what you might have learned or heard in lectures, that forceps are no longer needed and we only use elevators, or the last time we used forceps was 40 years ago. Well, forceps are needed. They are the best tool. As long as you have enough coronal tooth structure, they're the best tool to mobilize a tooth. And as we'll see, mobilization is the first step of every extraction. So don't throw your forceps in the garbage. Don't give them away. You need forceps, but you need to know when to use them and how to use them inside the extraction plans. Let's start. Before we do an extraction, I'm going to review a quick analysis that will allow you to review the X-ray of the tooth. And this is really what I use. 90% of all cases, I can determine the extraction plan based on an X-ray alone. A simple PA is going to do it, and I can derive 90% of all cases or 90% of the plan just from an X-ray, okay? Your extraction plan is right in front of you in most cases, okay? Of course, there's some hidden scenarios, and of course, we have the option to do 3D scans, but you don't have to buy a scanner. You don't have to get a 3D image for every extraction, okay? Maybe if there's nerve proximity. So why do we need to analyze an X-ray before an extraction? Well, we need to analyze so we can visualize, so we can see and we can understand what we're facing. And why do we need to visualize? Because we need to identify all the factors that are going to make the extraction more complicated or challenging. What is going to be working against us as dentists when we are extracting a tooth? You want to identify those factors in the periapical X-ray. We call them extraction enemies because the enemies are the ones that we need to fight and tackle and prepare for. This is a war, and the more you're prepared, the higher the chance that you're going to win that. And there are different types of extraction enemies. We identified 10, but I'm going to share with you the top 4 extraction enemies that we see in our practices. Number 1 enemy is an endodontically treated tooth. These teeth are hollow from the inside. They're weak and brittle. They're more likely to break in different spots. We'll talk about the exact spots where they break. So when you are identifying an endodontically treated tooth, well, that tooth has a higher risk of breakage. And I think this is pretty clear. The second most common extraction enemy is dense bone. Well, dense bone is a great thing for implants, great thing for longevity and the health of the jaw. But when we're extracting teeth, it's going to act against us. Not that it's impossible. We'll have to navigate that challenge, but it's a mobilization issue. We're not going to be able to mobilize a tooth as readily in bone that is dense versus bone that is more porous or more soft. Extraction enemy number 3 are curved roots. Well, curved roots, each root has its own path of exit, and we're going to be facing access issues, undercuts, periapical infections that are pretty hard to reach. Well, this is why there is splitting of the roots, and there's ways to remove teeth with specialized instruments that is going to mitigate that challenge. And enemy number 4 is the remaining tooth structure. This is really important. It's mostly a grab issue. So if you have total destruction of the coronal tooth structure, well, you're not going to have much grab. And that's why we have plan A, B, and C that will allow you to handle the different scenarios. So it's important to tackle those extraction enemies, but also when you look at the X-ray, you need to know the average anatomy of the tooth that you're extracting. And we know the basic anatomy, the number of the roots, the curvatures, but I also want you to be aware of the anatomy in cross-section. What does it look like at the coronal third of the root, the middle third, the apical third? And you need to know that. And it's very simple from the anatomy book, and we all more or less know this, but it's good to review this because the more you know the anatomy, the better you'll have the ability to extract these roots and have better strategies and tactics to extract them. Mostly the middle third of the root where we sometimes need to operate. So you want to visualize the root shape. You want to see where the curvatures are. You want to see where those undercuts are, okay? And this is where you can predict the point of breakage. This is where roots break, exactly where the undercut is. And with proper side cuts, splitting of the roots, you're going to be able to, again, mitigate that type of challenge. How much tooth structure is left? We're seeing, this mostly restorative material. There's not going to be much left of this tooth structure. So we need to pre-identify it and also build into our extraction plan what type of maneuvers we're going to execute so we extract this tooth in a simple way, in a time-efficient way, etc. We're also looking at other things. What type of structures can be damaged during the extraction? I obviously look at the adjacent teeth. Are they brittle? Is there any problem there? We don't want to lean against an adjacent tooth and damage that while we're trying to extract a neighboring tooth. But also proximity to the nerve, especially with third molars, but also for lower second molars, lower first molars sometimes have nerve proximity, especially if there's a large periapical lesion. So we don't want to get any patient numb, but we want to get them numb for the procedure. So if you don't analyze the periapical infection and you just go for it and you just try to anesthetize them the day off, well, sometimes your block is not going to take and your local anesthetic is not going to be efficient. So my recommendation to you is look at periapical infections. You might want to place the patient on systemic antibiotics 2 days before. The infection will shrink, your local anesthetic is going to be more efficient, and you'll be able to extract and get the patient numb and make sure that you have a patient that does not feel what you're doing to them, okay? The periapical radiograph also helps me plan my extraction, helps me plan the tactics for extraction. Where am I going to create a split? For example, a split between the mesial and distal root of a lower molar. Or if I have a curved root, what type of side cuts am I going to create? Especially for undercuts and curved roots, we want to eliminate that undercut by creating a side cut along the root. And of course, we want to be as conservative as possible. We want to preserve the interseptal bone. And this is why we have an extraction plan or a recipe that if you follow it, you'll know when to make those cuts and when to make those splits. Now, if you're wondering about reaching out for any tooth out there and not having clarity about the tools, which we call the black hole of extraction tools, you're not alone. A lot of dentists either use too many tools or try to use too many tools, or they try or use too few tools, or use the wrong tools, or use them in the wrong way, okay? If you have a proper plan and you know which tools you're going to use for which scenario, in which order, what is the predictability? What is the likelihood that you're going to have a way more smooth extraction, more predictable with less stress and less sweating? Well, it's going to be pretty high if you know when and how to use the tools. So let's get rid of some of that black hole for you. Extraction tools are not that complicated. We have 3 major types of tools. We have forceps that allow us to grab tooth structure. We have elevators that allow us to mobilize teeth, mostly side forces and sometimes even to elevate roots. And we have burs that allow us to split roots and allow us to create cuts. Well, forceps, we have different kinds. Well, you can look at the dental catalog and see hundreds of types and get confused and then close that catalog and just decide not to extract teeth. That's one option. The other option is to figure out what type of forceps are there. There are only 3 types of forceps really in the big picture without the small nuances. We have forceps that are meant to grab an intact coronal tooth structure, okay? They used to be called universal forceps. We call them forceps A, keep it simple. We have forceps that are meant to grab compromised tooth structure. We used to call them specialized. We call them forceps B. Keep things simple. And there are forceps that are meant to grab root forceps. We call them root forceps or forceps C. That's it. And all the different forceps out there will fall under one of these 3 categories. Different color, different handle, different material, different quality, but the principle is the same. So these are the 3 forceps, and please remember them because each forceps is going to match a different extraction plan. How about elevators? How complicated is that? We have thousands of elevators in a dental catalog. Well, there are only three groups. We have straight elevators, of course, different sizes, small, medium, large, typically. We have curved elevators. I like to use these elevators because they're called also spades. They have different angles that will allow me to mobilize a root and allow me even to reflect roots. And we have root picks. Root picks are a type of mini elevator that is meant for broken root tips, and I'll show you how to use them, okay? Let's get some clarity about tools. No need to be confused. Confusion is going to lead to paralysis, and you're not going to want to extract teeth. How about burrs? How many types of burrs are there in the catalog of Brasseler or any burr company? Thousands. Well, for extractions, we use three main ones. We use a thick sectioning burr. An example here is 702L. We use a thin sectioning burr, 700XL. And I also use the 151L, which is a very long burr that allows me to go down to the middle third of the root and sometimes even the apical part of the root because it's very long and pretty thin. These are the burrs that I use predominantly. Now, are there other burrs for other reasons, to cut off a crown, to remove the porcelain or the metal? Yes, there are, but these are the exact burrs that I use in my practice. So if you have clarity about the forceps, the elevators, the burrs, well, you're going to be so ahead in the game. So when you get into an extraction and your assistant has prepared all the proper tools in order and you have a plan, how confident are you going to feel with this extraction? This is my experience in my practice in Beverly Hills as a surgical specialist with my 25 years of experience and 25 years of education too, and extracting thousands and thousands of teeth. I still follow the plan. And the plans that I'm going to share with you in this training and in our future training are based on my experience, based on all the courses that I've taken, all the books that I've read, all the articles that I've read or written. Everything is inside all the extraction plans. Now, extractions have risks. We have to remember every surgery has a certain element of risk and complications that might happen. We need to be prepared and we need to be able to protect our patient from mistakes, and we need to be able to protect ourselves medical legally. So you need two things. You need the right consent form and you need something called the timeout protocol. What's the consent form? The consent form for extraction. What's the big deal? It's a form, they sign it and you do it. No, that's not correct. You need the right consent form with the right format, the right points, and there are 10 points. I'm not going to review them in detail, but when you look at your consent forms, make sure that they have those 10 points. The diagnosis, why you're extracting the tooth, what you're recommending an extraction, what are the risks, the fact that there's no guarantee or warranty that this is going to be successful, consent for unforeseen conditions, compliance with self-care, supplemental records, meaning you want to take photos, you want to take videos, your patient endorsement, the fees. Yes, I include the fees inside the consent. It's another place where the patient is committing to the fee, and 10 signatures. Okay, so 10 parts inside the consent form that I use, and we offer this consent form for the doctors in our training so they have the right consent with the right format. The second element is to do something called the timeout protocol for every surgery, but specifically for extractions. You want to make sure that you have the right patient with the right medical condition, that all the medications have been called in, that you have the right tooth and the patient understands what's happening, that your team is in tune with what you're doing, that you are prepared, and there's a script that I literally read out after my assistants fill it out before the procedure, like in a reputable hospital where surgery is done, a hip replacement, a kidney surgery. Well, we don't want to treat the wrong hip or take out the wrong kidney. That's not going to happen in your practice. We don't want to take out the wrong tooth. So we have a timeout protocol, and not only does it protect the patient and you, it also builds value to who you are as a doctor, using checklists, using systems, and being very methodical and organized. And this is how I like to run my life and run my practice. And I share this philosophy with everybody in the community. So let's extract some teeth. Let's talk about broken teeth and how to approach them, okay? Sometimes x-rays can be overwhelming. You might underestimate the difficulties here. You might overestimate and just decide not to do this procedure. The first thing that comes to mind when you're doing an extraction, don't just go for the tools and just do whatever you need to do. It's not going to work. You need to have a plan. And part of that plan, besides consents and timeout protocol and local anesthesia, we're not going to get into these details in this training. The first thing in an extraction, without exception, you need to mobilize. Mobilization is the key element for every extraction. That's loosening of the tooth or whatever is left of the tooth without trying to deliver it. You can do this with forceps. They're the best in loosening. If you have tooth structure, if you don't, you can use elevators. I'm going to show you how it works as part of the protocol. Don't try to remove a tooth without loosening. Loosen first. Even if you know you're not going to extract the tooth or if it's going to break on you, loosen it because it's going to pay dividends later on. If a tooth is loosened for a few minutes, the apex of the tooth or the periapical or the apex of the root gets mobilized as well. So when that breaks, it'll be easier to remove. So when you're looking at your x-ray, try to predict where is it going to break. Well, naturally, it's going to break probably at the base of the post or where you have an undercut and you're going to get a breakage there. So predict it. So when you hear the snap, when you feel that snap during, you're not like thinking, oh my God, what happened? No, you are predicting it. You might even want to tell your patient. You might hear a little crack. This is all normal. You probably feel some kind of pressure, no pain, but you'll feel something different. This is all part of the process because you can predict where roots are going to break. So here's the clinical scenario of the same tooth. We can see some gum recession. We can see class 5 restoration. We can see some furcation involvement, obviously. Well, this is a tooth that I can mobilize. I can use forceps B, which is what we call a specialized forceps, or we used to call it this way. And this forceps design has a perfect design to fit inside a lower molar furcation. You can grab it, find a comfortable spot, and start with rotational movements. Well, sometimes teeth, when they have an infection, that mobilization is kind of simple, and you'll be able to extract the tooth itself simply with forceps. But in this case, I heard a little crack. I felt a little snap as I was doing that. I was not surprised. I was composed. I looked at the tooth itself. Always make a habit of looking at the extracted tooth right away. Pass your finger on the apex and feel if it's smooth, round or not. If it's round, you're great. If it's jagged or flat, well, you broke it. In this case, it's pretty obvious that we are missing part of the root. This is not a complication. This is part of daily practice, extracting teeth that are broken. Roots are going to break. Whether you are an oral surgeon, a periodontist, an experienced dentist, a novice dentist, an intermediate dentist, it doesn't matter. Roots are going to break. You just need to know what to do about it. So I always take a post-extraction x-ray to visualize, although I know it's broken, what's left, and then figure out my secondary strategy on how to rescue it. Now, remember that I mobilized the tooth before. That means that that root tip has undergone at least 2 minutes of mobilization, rotational movements, side-to-side movements. I didn't just go in there, did what I needed to do, and picked an instrument and ripped this tooth out. That's not what you need to do. Dentistry is a gentleman, a gentlewoman's profession. You need to use your dentist's hands the same as you prep, the same as you do any other dental procedure. You do it with a gentle approach and in tune with what's happening inside the patient's mouth. Since I mobilized the root tip, I can now take a root pick and I can engage that root tip on the distal aspect. If I have some place, if I have a little spot in there that I can insert my root picks, I might want to just mobilize it. Well, it's worth a try. And these instruments are meant to do this. Now, if this doesn't work in the first 30 seconds, that root tip is not coming out. You need to execute a side cut. A side cut is taking that long burr, making a side cut along the burr on the distal aspect. Why distal? Because I don't want to damage the furcation bone if I can avoid it. And once I create that side cut, well, now I have room for the root pick to create more movement, and I might even be able to retrieve it. If it doesn't work out, well, then I can potentially go more mesial, or I can go a little bit deeper. I can trough around it. I can create what we call a circular cut, okay? All of that appears in our extraction recipes. But if you loosened the tooth initially, it's going to help you later, okay? Have the patience of a dentist, okay? Have the patience of a methodical and confident surgeon so you can extract these root tips. Now, can we remove a broken tooth with only forceps? Yes, we can, depending on the status. If you have a fractured molar, where the mesial root is definitely fractured in here, and we have a large periapical infection, and by the way, we don't want to wait for those infections to become too deep that the tooth just comes out, because then we are creating another problem, or the patient created it for themselves. Too much bone loss, you need more bone grafting, the site will be compromised. So if there's an infection, well, I'm going to still start with mobilization. I'm going to get a feel for the looseness of the tooth with my forceps. And the best forceps, if you have coronal tooth structure, the best forceps to use are forceps A. These are the ones that can grab the coronal tooth structure. You want to find the right spot. It doesn't have to be buccolingual. Sometimes the best spot, the most stable spot, is on the line angles. And once you got it, all you need to do is rotational movements for about 30 seconds to a minute. I like to go for a whole minute. I walk my patients through this, if they're not sedated, that they're going to feel some pressure and vibration. And that is the mobilization part. Once I'm done with the forceps, I'm still not going for the extraction. We need the patient. I'm going to do 1 more minute with a medium straight elevator. I'm going to use that elevator first mesial for 30 seconds, then distal for 30 seconds, without attempting to extract. I'm simply going to mobilize the tooth, obviously mesial distal. Teeth have PDLs and they can be mobilized. And only after I did the mobilization, I'm then going to separate the soft tissue. Some people like to use periostal elevators. To me, it's a bit crude. I like to use either an Orban knife and pass the Orban knife through the sulcus, or simply a 15 blade, okay? I just want to preserve that tissue, so when this tooth is ready to come out, I don't want to rip out the soft tissue, because we know how important soft tissues are. So look, we have a simple plan for this type of molar. I'm just going to briefly review it. Separate the tissue, use the forceps A, rotational forces, use the medium straight elevator, go back to the forceps for more mobilization, and try to deliver the tooth, okay? 5 steps, not that difficult. Doesn't mean it's going to come out, but these are the steps that I follow when I gauge that there could be some looseness of the tooth, and indeed there was. This tooth had a large infection, and once the mesial root kind of separated itself from the bone, or vice versa, well, the distal root was just simple to remove. So it is possible to remove a broken tooth with just forceps. Now, every broken tooth is different. Okay, I'm going to show you different types of scenarios, but there are patterns that you can see, or you will see, as you extract more and more teeth. So it's kind of the same, but not exactly the same. So you'll have to modify your extraction plan. Okay, this is a situation, again, we have a lower molar, the most extracted tooth in the mouth. We call it the money tooth for different reasons. And again, we have an infection of the mesial root. There was an attempt to do an apical years ago. Well, at some point, the tooth needed to be extracted. And you're looking at a scenario where there's an intact crown. Great, amazing. Well, I'm going to use my forceps A, but seemingly, because there's not a whole lot of tooth structure. And as I'm using forceps A and starting to mobilize the tooth with a medium straight elevator in the way I shared with you before, and it takes about 2 minutes, okay? You just have to be patient and count those seconds as they go by, and you can follow that 5-step plan. But what may end up may end up happening when you try to deliver the tooth with forceps, well, you're going to be left with the crown inside the forceps, and you're seeing the remaining tooth structure. Well, it's not the time to tell the patient, okay, I did what I could, and send the patient home. You need to have a plan B. So it's good to have a plan B, generally in life. That's a pretty good philosophy. Always have a backup. And the plan B is the plan B is a system to remove each root separately. And for that, you're prepared. Your assistant has prepared the right burs, the large split burs that are meant to separate at the frucation. That's what I use them for. And the long cut, which is meant to create those side cuts where I'm predicting that root is going to give me some trouble. So not only do you want to have the right burs, you want to know where to use each one of those. And this is what I'm showing you here in this slide. Okay, and this is at least how I do it for many, many years successfully. So for lower molars, you want to execute a buccal lingual section. So you want to start that sectioning process from the buccal. You don't necessarily have to reflect the flap, but often we need to. And you start sectioning that root from buccal to lingual. Don't go all the way like a train, because if you go too fast and too hard, you're going to blow out the lingual plate. You're going to cut through the soft tissue. We don't want that either. So as you progress from buccal to lingual, as you get close to the lingual, stop, look from the occlusion, see if you're almost there, and then finalize the sectioning. Once the teeth are sectioned, awesome. Now you have potentially a mobility of each root separately. Each root will have its own path of exit. And we use 2 tools for that, the medium straight elevator and the spades. Now, the spades for lower molars have almost a 90-degree angle. In our advanced courses in extractions, we talk about the exact tool selection and the exact design of the instrument. So you not only pick the right instrument, but you understand why you're picking it. So these are the 2 tools that I use after splitting the roots. And then it's just a patience game. I like to start with the medium straight elevator in about 45-degree angle, almost 90-degree if I can. Of course, not full 90 degrees is not possible. And I start by mobilizing the roots. I'm not removing them. I'm loosening them. Don't rush to remove it and move on. I know you want to, and I want to as well. I want to be a hero dentist, a hero periodontist that does every extraction in 5 to 10 minutes. Well, it's not always the case. We need to take our time to loosen and mobilize. And when they're loose and mobilized, only then we reach out to, it's actually forceps C, and we can now grab each root individually. Now it's mobile, and with some buccolingual movements, sometimes rotational movements, we can now rescue those roots, and we got a beautiful extraction socket with the frucation bone and everything else. And if you need to use a membrane because there was a large periapical lesion because of that apical, then you do that. But that's nothing to do with the extraction, okay? That's a completely different chapter that we teach as well in our platform. And you complete the bone grafting and what needs to be done in this case, okay? So by following the plan, you have clarity and you have confidence and you have a peace of mind that you're following the steps, okay? So plan B, to repeat that, is the sectioning, the loosening with the medium straight elevator and the spade, and then delivering either with an elevator, because roots, depending on how long or short they are, can be removed with elevators or spades. But typically, if we have a grab, we'll use forceps C. Now, you're going to see many, many repeating patterns. It's kind of the same, but not really the same. Okay, who wants to extract that lower premolar on that side with the 90-degree angle? Well, we're not going to do it because it's a perfect tooth. We're going to extract that lower first molar. Look at the roots. Look at the extraction enemies. We have an S-shaped root. Okay, that should give you an idea that this is going to give us trouble. I'm not concerned about the mesial root because it's swimming in infection. That's going to just come out, no problem. But the S-shaped root is going to require some special attention. I'm not going to go for the extraction. I'm going to mobilize the tooth first. I'm going to use my forceps A. I'm going to use a medium straight elevator. I'm going to apply that type of mobilization for at least 2 minutes, alternating between forceps, then the straight elevator going back to the forceps. But we know that that crown might come off from the loosening process, which is basically rotational, or from the side-to-side movements, or sometimes we do it intentionally. We know that crown is going to come off, and it's actually not a bad thing because it's much easier and less time-consuming to split buccolingually when you don't have the crown anymore. And here I might have rushed. You see, I created a little nick here on the lingual tissue. Okay, I'm not a perfect surgeon, but when I have the crown removed and I'm looking at the remaining tooth structure, I can now split with confidence if I know which burrs to use and how to use them and when. Okay, so again, the large split burr is mostly for the furcation bone. The long cut is mostly for side cuts. And I definitely want to create a side cut when there's a root that has an S shape. No matter how exaggerated this S is or how extreme this S is, we want to create some side cut to allow the tooth some mobility and some space to move in so I can deliver it intact. I don't want to break that root tip at the bottom, although that happens as well. So once I split the roots, I'm going to mobilize them, medium straight elevator, a spade, not trying to remove them, side-to-side movements, mobilization, and only then do I reach for the forceps C, the root forceps, so I can remove the roots predictably, and of course take an X-ray after that. As I anticipated, one root was removed intact. One root was removed broken because it was broken to begin with. Okay, I followed the plan, and this is why I'm able to predictably extract teeth in a shorter period of time with less stress for myself and my team, less stress for the patient, also not running behind. And once I have a great extraction, I can focus on bone grafting using a membrane where the buccal plate was missing and make sure that I have a good bone grafting procedure. And this is just showing you that we have a good implant site. Implant is there, integrated and ready to be restored. And I believe that the key to get this implant to work and for the bone graft to work, we actually have to go back to the first step. We have to do a great extraction. And you cannot do a great extraction if you don't have a plan and the exact steps that you follow in a methodical way. And it's not that difficult because you have a plan. Have you tried cooking by improvising? Well, you know, that cake, that dish is not going to taste good because you're improvising versus following the recipe of a master chef that taught you how to do things, okay? By the way, you don't always have to start with plan A, although I always recommend you mobilize while you have the coronal tooth structure. You can intentionally remove the crown and continue with plan B, which means the splitting and the mobilization of the roots, okay? That's possible as well. Now, what do you do if a lower molar is fractured mesiodistally, okay? Well, you don't have to reinvent the wheel. Remove the broken part, see what's left, split the tooth again from buccal to lingual, stop right before you finish get to the lingual aspect so we don't damage the lingual bone and tissue. And once you confirm that you have another 0.5 millimeter, then complete your split, follow the mobilization protocol with a straight elevator or a spade, use your forceps C, the root forceps, remove each root separately, bone graft, and you're going to get a beautiful extraction process, a beautiful bone grafting process, and a predictable implant site. And this shows you all the steps. And we go through a lot of steps to get to when the implant is restored. Well, it all started with the extraction. So if you're not doing extractions, you are limiting what you can do later. You're limiting bone grafting, you're limiting implants, you're limiting implant crowns. And of course, you can refer to somebody else and get the patient back. But you know what? Honestly, the patients, once they see the surgeon, and I can talk from personal experience, they're going to stay with that surgeon. And that's sometimes okay, and sometimes good. And I'm very happy about referrals. I'm a referral practice. But if you're not doing extractions, you're not going to have the potential of growth with all the other procedures, okay? So these are lower molars. Let's switch to upper broken teeth, okay? Upper molars with the 3 roots. Seems more difficult, but not really, because yes, we have more roots and we have sinus proximity, but we have softer bone, okay? So we have some pluses and some minuses here. So always identify the extraction enemies, and I always start by visualizing the outline of the roots. We have those 3 roots, mesial, distal, and palatal, mesiobuccal, distal buccal, and palatal root. I know the anatomy of the roots, not just mesiodistally, but in cross-section. It's not that difficult. We learned about it in dental school, and we provide this in our training. And I'm identifying 2 main enemies. I'm identifying pretty steep curvature of the roots. I'm identifying an S shape of the distal buccal root. I know what I'm getting into it. I have intelligence. It's going into battle. I'm going into a war, small war. Well, I want to gather intelligence to know who the enemy is so I can address it with my extraction plan. So I know for a fact when we're dealing with a tooth that is that broken and has these very clear extraction enemies, and who knows, maybe they're even fused at the tip. I know I need to do some splitting. I'm going to go directly to plan B. I'm going to loosen. Well, I can't grab the tooth with forceps. I'm going to loosen the tooth with a straight elevator. Okay, I'm going to use my elevator mesial and distally. I'm going to try and be very careful about the adjacent teeth. If they have crowns, I don't want them to pop or the teeth to break. And after I do that, I'm going to split the tooth in two main types of splits. One is called the T, one is called the Y. And you all heard about it maybe in some of my previous videos in short, but let's get clarity about the T split and the Y split and why do we choose between the two. So what's the T split? The T split is a split in a shape of the letter T. So I'm going to split between the mesiobuccal and the distal buccal root first, and then I'm going to separate it from the palatal root, and that's why we call it a T. Well, it's a T standing on its head, but it's still a T, okay? Now, what's going to happen here? Well, we have the potential, as we separate the palatal root, we have the potential to damage the adjacent teeth. We don't want that. So it's not a great design. A better design for this type of scenario is called the Y split. We're still splitting between the distal buccal and the mesiobuccal root. But as we separate the palatal root, we're going to go actually diagonally towards the line angle of the adjacent teeth. In this case, the palatal line angle of the second molar and the adjacent premolar. This way, we bypass the teeth. We still separate the palatal root, but we don't damage the adjacent. And as we separate them with the large split, now we can mobilize each root separately. Spend a good minute doing so. If you can't really mobilize, execute some side cuts to give the root some mobility, and we use the long split for that. And then once they're loose, then use your forceps C, the root forceps, and deliver all 3 roots successfully. And there's nothing better than executing something like that. And I'm not going to put a time frame to it, but if you can accomplish all of that, in around 15 to 20 minutes, it's great. And some of you are maybe faster, some are slower. It's not about the time. It's about the safety and the predictability. You don't want to rush something, break root tips, push them into the sinus, and then spend, another 2 hours and unsuccessfully so. So it's sometimes better to spend more time initially to have more predictability. I had a little boo-boo here, a little ouch of myself. I split the roots and I went a little bit too deep into defrucation. It happens. We can't always predict 100%, but I'm showing this to you because these things are going to happen. It's not the end of the world. I still retained the defrucation bone, but we should be as careful as possible to not damage the defrucation bone. And these are the steps. So by me and by you extracting an upper molar predictably, you open a world of opportunity for bone grafting, for sinus lifting, for implants, and being able to do so if you have a plan for the extraction. So should we do a T or a Y? Well, depending on the case. If you have adjacent teeth, well, it's better to use the Y, like in the case I just showed you. If you have one adjacent tooth, well, we don't want to use exactly the T. It could be maybe a combination, but we don't want to damage that tooth. We can utilize the T, but on the mesial aspect, we can definitely combine like a T and a Y combination. But I leave it up to you. As long as you separate the roots in a safe and successful way, and you separate them and rescue them, each root individually after proper mobilization and using root forceps and following a plan, you're going to be very confident and very predictable, and you're not going to sweat. You're not going to have that stress and running behind that we have. Number one, you're going to allocate enough time. That's an important part of every procedure, not to have too little time. But if you follow the plan, you're going to be, in 90% of all cases, you're going to be way more predictable and more time efficient as well. This is the case afterwards, showing that we had the opportunity, following a good extraction, to do bone grafting, probably some sinus lifting, and proper implant placement. So these are the molar teeth, upper and lower molars. What happens in the aesthetic zone? Well, everything matters in the aesthetic zone. It's a little bit more stressful. We're going to have tons of trauma cases coming our way where teeth are broken subgingival, subosseous. Teeth are damaged. Well, we have to think through the extraction process. We can't just go for it. We can't just grab something, a tool of some sort, and try to pull the tooth out, because we're going to create soft tissue damage. We might create papilla loss. What is this going to do to a future implant site? What is that going to do to the papilla and the recession that might happen? So the trauma is real, but I don't want you to be traumatized, and I don't want the patient to have further trauma. Here's an example of a patient that had trauma, unintentional. She had a surgery in a hospital, and during the intubation, the anesthesiologist actually broke her tooth. And you can see that fracture, subosseous, horizontal. We know that tooth is hopeless. And once that crack starts to get exposed to the oral cavity, well, it gets infected and it's game over. The patient can live with that tooth for a few months. And sometimes I've seen patients live with that type of trauma for a year or two, but eventually that crack line gets infected. When it gets infected, we're in a world of trouble. So why am I showing this case to you? Because I talked to you about mobilization. Well, you can't loosen up that apical part of the root. You can't, because once you apply pressure, once you apply mobilization, rotational forces, side forces, with the same methodology I shared with you, you're going to be left with the crown in your hands or on the surgical tray. And then you need to use all sorts of tools. Can you use forceps? Not really. Well, you're going to use the forceps to remove the coronal part, but maybe you can use straight spades or small, medium, straight elevators. The problem is that the thing is just caught in there, pretty deep in there, and it's going to be pretty hard. You can create side cuts. Well, that central incisor has root proximity with the adjacent lateral incisor. That's going to be hard. I might need to go more on the mesial. Well, I try not to. I don't want to compromise the papilla, but it's one of the options, really the last resort. This is like plan C. So let me share with you what I did in this case. So first, after separating the soft tissue, we want to be very careful. You can see that the tooth has those smaller capillaries and the tissue quality is not great. I'm going to use the forceps A to remove the coronal tooth part. Now, I would hate to disrupt that soft tissue. It's not a crime. You do what you need to do sometime because you don't have the awareness, but I like to use the vertical extraction technique. So when I have those root tips that are sub-G, subosseous, there's a vertical extraction recipe where I engage the residual root tip with an extraction screw. That extraction screw gets connected to a cable And that cable is connected to a pulley system. It's called the Benex system. We call it the vertical extraction Benex protocol in our training. And by connecting it to the pulley, that pulley is now going to apply vertical pressure on that root tip as long as that extraction screw is engaged. And by rotating a knob very simply around for this pulley system, we're going to get a perfect vertical extraction with minimal trauma to the socket. It's very, very helpful. And we have that protocol inside our training. So the aesthetic zone requires a level up of care and sensitivity and planning, and maybe using something like the Benex system. Now, if you don't have the Benex system, well, there are other systems, and there's ways to extract these teeth differently that we teach as well. But this is the ideal system for this indication, and it's worth the investment. So as you become more knowledgeable about extractions, and as you become more confident and clear about how things should be done, and you're clear about extraction plans and recipes, well, you're going to be more confident about extraction cases coming your way, because they come your way all the time. You're going to start seeing patterns of how teeth break, in what ways to extract them. You're going to see combination cases where you see, for example, here, a tooth that is completely destroyed, a premolar next to a molar with a large periapical lesion and a fracture in the root. Well, you might need to combine different extraction plans or recipes and combine them together. So if you don't have the clarity right now about this type of an extraction and the stages, well, pay attention, because I'm going to share just in a very simple way what I did here. We have a tooth that is extracted and decayed at the gingiva. No forceps can mobilize this tooth. If I'm going to start using forceps, I'm going to just clip the soft tissue and create unintentional gingivectomies. We don't want that either. So for this case, I used the zone vertical extraction system or a recipe, similar to what I did before. It's not just for the aesthetic zone, it's also for premolars. I placed my extraction screw. I connected that extraction screw with a cable to the pulley system. That white part is called the occlusion bumper. It's placed parallel to the occlusion, and it's perpendicular to the extraction screw. And then that pulley has a knob, and I rotated clockwise to pull, wait for it to tighten. That's when the root starts to create some resistance because the PDL fibers are stretching. And then I'm going to let it be, rotate counterclockwise, let it be, create some looseness, do it maybe 3-4 times. And then eventually that root tip is going to come out. Okay, for most cases, this is a very elegant way to extract the tooth without making cuts and splitting. And you see the splitting here wouldn't have been easy because we have roots that are more or less fused almost to the middle of the root. How about that molar? Well, for that molar, we're going to apply the extraction plan that you saw before. I'm going to use some mobilization or loosening. That loosening eventually is going to loosen that crown, and we're going to remove that crown. And then we apply plan B, which is our T section. We no longer have adjacent teeth. We don't need to utilize the Y. Don't be a robot dentist like, I'm going to do a Y no matter what. No, you don't have to. A T is actually much easier than creating the shape of a Y. And I'm going to split the coronal part all the way to the furcation or the trifurcation with my large split. And if I need to create some side cuts, because the root is stubborn or has some curvature, I'm going to use the long cut, the 151L. And once I create that type of separation, don't go for the removal. Don't go for the delivery. Don't rush, because rushing is not something that is going to work for you. You're going to end up spending more time. Once you split them, each root has its own path of exit, but don't rush to remove them. Focus on loosening. Use your medium straight elevator or the large straight elevator. Start to loosen each root separately. In the furcation, mesial, distal, don't go buccal, there's nothing to lean against. And only when those roots are loose, and sometimes you need to create some side cuts, okay? That depends on the situation with the long burr. Now you can remove each root separately. Take that root tip, pass your finger on the tip, make sure that it's nice and round. Do your bone graft, do your PRF membranes, whatever grafting technique you're using, that extraction unlocked more potential in your practice, not to mention doing the implants. And why? Because we were able to execute on an extraction in a simple, elegant, and predictable way by using that extraction plan. How about the aesthetic zone? Well, there are other things you can do in the aesthetic zone. There's something called the socket shielding technique. I'm not going to get into it in this training. How do we execute extractions of teeth that are periodontally compromised? And you're like, oh, this is not a big deal. I'm going to close my eyes, just rip this tooth out. You're going to have a rude awakening. These roots are going to break. So if you're not going to spend enough time mobilizing the tooth and mobilizing those root tips, and those roots, one of them, it has a significant curvature, the mesial root, and the distal root has a clear S shape, you're going to be in a world of trouble rescuing those root tips. But if you apply mobilization, you apply side cuts, you'll be able to remove them. Same with other cases in the aesthetic zone. And this is why we created a system called the zone extraction method. And it's based on my 25 years of experience as a surgical specialist, extracting thousands and thousands of teeth, seeing what works, what doesn't, and simplifying the process of extracting teeth. So every dentist that follows this system has that 95% predictability of being able to extract teeth in a very simple and predictable way. And this is something we called the zone extraction method. So it's a method to extract teeth in an elegant, effective, and predictable way. And what is it based on? We have a finite number of teeth in the mouth. Okay, we have the molars, premolars, canines, and incisors. Okay, all of these teeth can present with a scenario of extraction. Now, we don't have infinite numbers of scenarios. I mentioned before, there are only 3 scenarios for each tooth. Each tooth can present with a complete crown, with a damaged crown, or no crown. And for every tooth in the mouth, and for every scenario, we created a recipe. So this was a lot of work, obviously, but the work was not the few months we worked on it. It was the 25 years of experience where Dr. Riemann and myself figured out how to distill an extraction protocol that seems complex, where there's no standard in dentistry, into mostly 3 pages of everything that you need to know. And the most important is the plan to extract a tooth in every scenario. And we put this all together inside the zone extraction method. We also put it in a recipe book. We have a book that dentists that want to learn about the zone extraction method will get that recipe book, plus the digital copies of every recipe, because those recipes get updated with time. And we have many, many recipes in this book. It's a book where we have over 350 new illustrations to make the extraction a piece of cake, simple. So basically what it is, it's a system, but you can learn this system as part of the zone extraction method course. And we're going to open registration today to another cohort of dentists that want to have the skills and want to have clarity to extract teeth in a predictable, elegant, and efficient way. So part of this training is seeing how surgical specialists like myself, like an oral surgeon, extract teeth. We call it the perfect pull. So we're giving you the recipes to extract teeth, and we're giving you tutorials for each type of scenario. So if you have tomorrow morning, you have an extraction of an upper molar, all you need to do is open your recipe book, watch the relevant tutorial, and review the extraction protocol for that molar, whatever it may be. You will extract a lot of teeth. So there are a lot of protocols in this book. So part of this training is to see how myself and an oral surgeon execute these protocols in the real world with 4K high resolution close-up microscope footage to see how I do this with narration, with extreme close-up into the extraction socket, into the tools, while I give you all that training so you too can extract with intention. You also get the instrument clarity. What does that mean? We get rid of the black hole of tools. You no longer need to use too many tools, too little tools, or the wrong tools, or use them the wrong way. You only need to prepare the exact tools for the case, and you follow that recipe, which is very clear inside those protocols. Now, there are 32 teeth in the mouth. 4 of them are wisdom teeth. We're including wisdom teeth extraction in this course. It's included. So you're getting the exact recipe for every wisdom tooth and every wisdom tooth scenario. We identified 4 scenarios. There are more, but the 4 major ones, and this is taught by an oral and maxillofacial surgeon. I'm a periodontist. I'm not going to be there teaching you how to extract wisdom teeth. I extract a wisdom tooth a month, once a month, maybe one, if at all, because I don't like doing them. Maybe now with the recipes I'll start, but it's not my passion. An oral surgeon extracts 100 teeth every month, thousands of teeth, tens of thousands of wisdom teeth, and they are positioned to teach us how to do this. So we are, in this course, we created the recipes for wisdom teeth extraction. And we call them the black zone for the lower molar and the white zone for the upper molar. Okay, by the way, the zone extraction method is all color-coded. Every tooth has its own color coding. And we have more pages for wisdom teeth because we simply have more scenarios. And most of the illustrations are in this section of the course and in the recipe book. And you're going to learn from Dr. Brittany Sonicson all of these protocols on the step-by-step extraction of wisdom teeth. So it's really the first course that is out there taught by 2 different surgical specialists, a periodontist, and we know the advantages and the fortes of a periodontist, right? The soft tissue, the care for the papilla, the gentle movements, and oral surgeons. Not that oral surgeons are brutes, not at all. Oral surgeons are excellent at what they do, but it requires different knowledge of the anatomy, different handling of those impacted wisdom teeth. And this is why we decided to create a combination of educators that are 2 different types of surgical specialists with 2 different approaches towards extractions. You're getting both in the zone extraction method course. Now, we all know that dentistry is difficult on the body, also on the soul and on our mindset, but also on the body. We have back problems, we have neck problems, we have some sight problems, hearing problems. Well, I don't want you to have a sore back or a sore neck. And there's something called extraction ergonomics, where in short and concise videos, you're learning the exact positioning of the surgeon towards the patient positioning, the footwork, the leg work, and how you position the patient's head, chair position so that you don't get a sore neck and a sore back. And that's also included inside the zone extraction method course. Now, aesthetic zone, like I mentioned before, is a special region where we have to be very careful. And it can give us a little bit of palpitations as the dentists, and we need to use more caution. So there's a section inside the zone extraction method that teaches you aesthetic zone exodontria. So you'll see this inside the surgical demonstrations, the microscope footage, but you'll also see different methods to extract teeth in the aesthetic zone. For example, the step-by-step socket shielding approach, where this is the ultimate way to preserve the buccal plate and the buccal tissue to get robust ridges in the aesthetic zone, where it's extremely important. So this is included inside the training. In the course, there's so much there. We wanted this to be comprehensive. So anything that you need to know about extraction. So we're including the extraction protocol that is the timeout protocol, where you focus everybody in the room, before the extraction, you have a script that you review, like a seasoned pilot that goes through a checklist before takeoff. You'll be the same doctor. You'll create a lot of value for yourself. You'll create a lot of safety. You'll protect your patient and your practice from extracting the wrong tooth. And you'll simply be more focused and clear. And so you will be your team. Very important to give proper post-op instructions. If you don't give the right post-op instructions, even if your procedure was flawless, you're going to have more complications. So we're including the exact post-op instructions that I use myself in my own practice. That includes everything that you need to discuss, including the medications, including where I customize the instructions for my patients to give them that TLC, that extra mile I go for them, that place to write your cell phone, and how I give the instructions. This is all included inside the zone extraction method course. It's a short and concise course. You can go through this in probably a weekend. If you want to binge on it over a day, you can do that as well. Maybe 2 days might be too much. You have access to the course for life. As long as there's internet, as long as the course exists, you have access to that course. And you'll also be getting 18 AGD PACE CE credits. So what's included in the zone extraction method course? So first of all, you're getting those extraction recipes and those tutorials that walk you through each scenario, each tooth in the mouth, and give you the clarity about what to do in each scenario and the exact recipe. Then you're seeing video footage of surgical demonstrations. You're getting wisdom teeth extractions and the tutorials about that as well, the white and black zones, the extraction zone exodontia, and extraction ergonomics. A lot of value in a short and concise way. It took 25 years to get to this point where personally, and same with Dr. Ryman and other dentists that follow the zone extraction method, are able to extract teeth with elegance, with efficiency, with confidence, with predictability. That course normally is offered at about $2,000, $1,997. You can join this course today with a large discount for $1,497 or for $540 in our payment plan. Doesn't really matter. And we are opening registration today. You can follow the link on this page. Go there, read about the zone extraction method course, see what's included, read some of the testimonials, look at all the details of what you're going to benefit from this course. And then you have an option to join either with a 1 payment or 3 payments, whatever works best for you. But what's important is when you join, you have immediate access to all of the content in the course. Now, the course, like all of our courses, is fully guaranteed for 30 days. You take the course, you can go through the whole content if you want to, all those 18 hours of content, learn the extraction recipes, take the program, and if for whatever reason didn't work out for you, was not the right thing for you, you decided that you don't want to do extractions after all, well, just let us know and you get fully refunded. So there's absolutely no risk in joining this course. Now, like in all of our courses, when you join, you're going to be getting 1-year mentorship with myself, with Dr. Ryman, so you can review your extraction cases. This is monthly coaching done online. You can present your cases if you want to go online with us and speak to us and chat for a few minutes and review your course, or you can present cases that you've done for some constructive feedback. It's a very safe environment. It's a safe haven for dentists in our community to be able to share cases. And you can learn not just from my own teaching and Dr. Sonicsen's teaching, but also from other dentists' challenges. Okay, some dentists ask all the questions you never dare to ask, and vice versa. You might help other dentists to be better. So we have a wonderful community of like-minded doctors. You're getting that bonus 1-year training. And the value of that is, if you joined it separately, is close to $5,000 per year. Now, the course itself, the zone extraction method course, does not expire. You have access to it. You have a 30-day guarantee. The yearly mentorship, the monthly mentorship for 1 year, that expires after 1 year, and you can renew it if you want to, or join one of the other courses and you get another year. If you join this course, we also share with you a very important training. To do a predictable, elegant, and safe and time-efficient extraction is one thing, and to do it at a pro level, like a surgical specialist, following those recipes, that's one thing. That's great. But there's a step before where you have to communicate to the patient how things are done and how you do things and what are your recommendations. You can't wing it. So we have a system on how to present and sell. Yes, we need to sell. We need to present in a professional way that you are the right doctor to treat. Otherwise, if it's all the same and every dentist is the same, well, it's just a commodity. Well, I might as well go to the cheaper doctor, because it's like buying a bottle of water. Who cares if it's $5 or $2? I'll buy the $2. It's the same thing. It's water. Okay. In this training, I'm teaching you how to present and sell extraction procedures, how to talk to your patient, my case presentation system. And it's simpler than you thought. And I'm giving you the actual script that you can utilize. So when you join the zone extraction method course, you're getting this training as a bonus. The third bonus is a very special training that a lot of dentists don't have. We all know that teeth need to be removed. We know that. But we also know that implants fail. There's a certain number of implants that fail in your hands from other dentists. You need to be able to remove them. Well, it's not a tooth. There is a system to remove implants, again, in a predictable way. And removing implants is becoming another growth center in my practice, because more and more implants are being placed improperly without the proper care and maintenance, and they need to be removed. And you can't just take forceps and loosen them, because they're not going to loosen. They're partially integrated. There's a system to remove dental implants. I call it the Explant system. When you join the zone extraction method course, you're going to get that system, that training as a bonus, because I want you to be able to be an expert in extracting teeth, but also have the opportunity and the knowledge and the clarity on extracting implants or explanting them. That's the term we use. So today's offer is very simple. Join the zone extraction method with all the tutorials and the extraction recipes. You're getting those 3 bonuses: the monthly coaching, the case presentation system for extractions, and the Explant system, the implant removal system and training that you can utilize in your practice. And all of that adds up. We are now up to close to $8,000. We're now offering this to you for $1,497 or $540 in our payment plan. It doesn't really matter. And you can join by going to the link on this page, read about the course, pick your payment plan, sign up. You can immediately join the course and watch the content. I know a lot of dentists are referring their wisdom teeth out. A lot of dentists are referring molar extractions, simple extractions. Well, you don't have to specialize in extracting periodontally involved teeth that have class 3 mobility. That kids can do. That anybody can do. You don't have to attend this training or the course. If that's your goal, you don't need it. Okay? A tooth that has class 3 mobility, you don't need a recipe. Okay? It's recipe 0, plan 0. You need a plan. So when you join the course, and this is new now, you will get shipped to you the zone extraction method recipe book with all those recipes. So you have a resource in your practice for you and for your assistants to review, plus you're getting those recipes in digital format. So imagine you're taking the zone extraction method, and from this course, from this investment today, you extracted 1 molar, 1 lower molar, which is presenting to your practice like once a week. You have somebody who needs a molar extraction or a premolar. If you extracted the tooth in a predictable way, in a stress-free way, and you're able to do a bone graft, and maybe you would be able to do an implant on that site and restore it with an implant crown, that extraction alone is going to be worth the cost of admission, the tuition for this course. And I'm thinking you're going to get an ROI that is probably tenfold. And we have a lot of doctors that take our training. We cannot promise that you're going to increase your production like Dr. Acosta. It wouldn't be fair, and it wouldn't be even legal to have an income promise. But it makes sense. You're a dentist and you have patients that need tooth extraction. If you're not providing extractions because of the lack of confidence, because of confusions with the tools, because it's a mystery, or you just want to just refer them out and you just want to do the drill and fill or just focus on crowns and veneers, that's okay too. But it makes sense that if you include extractions, you're going to create another growth center in your practice. And if you're doing extractions, but you're struggling, or you want to do things more at the level of a specialist in a methodical and simple way, well, it makes sense that your production is going to grow. So registration is open to the zone extraction method. You can follow the link on this page. We'll also put it inside the chat. You have immediate access to those zone extraction recipes. A lot of dentists have actually laminated them. I did too, because it's nice and resilient, but now you're also getting the recipe book of the zone extraction method. So your assistants need to be part of it. They need to understand that method. There are 8 steps in the method. Okay, I'm going to review the book in just a second, and you'll be able to update, educate your assistants in regard to the method. They're going to love you for that, because they don't have to give you like 30 tools. They're just presenting you the tools that you need in the right order depending on the scenario. So more and more dentists all over the world are using the zone extraction method to extract teeth in a simple way, in a cost-effective way, in a time-efficient way, in an elegant way, in a predictable way. And that's really the key. Nobody should be sweating and cursing a root tip that got broken. And root tips are going to break. This system is not a guarantee that you will not have complications. This is not a guarantee for no dry sockets in your practice. You will get some dry sockets. That's not up to you. You'll decrease the number of dry sockets because you'll be extracting more efficiently and less traumatically. But you will have complications. It increases your predictability to 95%. So registration is open today to the zone extraction method. To join, go to the link on this page, pretty clear, extractionprogram.com. Read about the course. Join the course with the whatever payment plan is good for you. And I look forward to seeing you inside the zone extraction method. And next, I'm going to share some information from the actual book itself. I'm going to share my screen one more time. And let's try to make sure that you see all of that. This is basically the book. I'm going to go back to the beginning. Okay, so this is the zone extraction method recipe book. It has all the recipes, all the protocols that you need for an extraction of a tooth, any tooth in the mouth. Pick one of the 32 teeth, and you'll learn exactly what you need to look at, what are the extraction enemies, what tactics you need to use, what tools, the anesthetic, the positioning of the patient, and the most important part, what extraction plan you need to use. And that's true for every tooth in the mouth, for the lower molar, the lower premolars. And of course, every tooth has its own recipe depending on the scenario. And we spent quite a bit of time, and this is very detailed work. And trust me, it's easier to just throw things at you in a non-organized way and just you figure out yourself, like most of the courses out there. And there are very good courses out there and very good educators out there, but they did not do the due diligence of distilling their knowledge like we did in this course, Dr. Rashad and myself, for hours and hours, and I don't know how many hundreds of hours it took. And it was an effort well worth it, because we have a body of work that now thousands of dentists around the world can utilize in a simple way, in a clear way. We have over 350 illustrations in this book, from the uppers, the lowers. Here's the socket shield protocol, exactly what scenarios to utilize, where to make those cuts, what instruments to use. We have our vertical extraction protocol. You saw briefly inside this training. Wisdom teeth protocols. Lots of illustrations there, different scenarios that you can learn from about wisdom teeth. These are upper wisdom teeth. We got lower wisdom teeth. We call them the black zone. And once you identify the tooth that you're about to extract the next day, do yourself a favor, do your patient and your team a favor, review the protocol, review the tutorial, prepare yourself. It's not that difficult because we distilled that knowledge into simple steps. And inside the book, we also have the post-op instructions. You also have it as a digital copy inside the book, the timeout protocol that I mentioned before. And just simply browsing through this book is going to show you not just the amount of work. I don't need the accolades for doing a lot of work. That's a given, because that takes a lot of work for a small team to do. But when you join the zone extraction method, we are going to send you that book. Now you're looking at a digital copy. It's easier to obviously look at. And that level of clarity is second to none in our industry, because it was never done before. And for a reason, because it just takes a dedicated team to distill what seems to be complicated and a mystery into very clear protocols, step by step, and what we call recipes. So I welcome the many doctors that are joining the zone extraction method course, and I look forward to seeing you in the training. And I want to see your cases come to fruition with great extractions that are simple, predictable, and very importantly, elegant and safe for your patients.
Thank you, Ziv. Thank you for sharing your knowledge, and thank you for letting us look behind the hood of what you do. Because I'll tell you one thing, I was that dentist that give me whatever tool is there. I grab the tool, I go in, and I start yanking on the tooth and cross my fingers that the roots don't break, and just extracting teeth in a reactive way. And I truly believe this course, the way you've shared it, the way you break it down, it's kind of like an inside look on how your mind works. And I'll tell you what that did for me. It made me go into extractions with ease, with clarity, with confidence, and it allowed me to be able to charge a lot more for what I do. I don't do $79 extractions or $99,999. Why? Because I'm operating at a high level. I work and practice in Beverly Hills, California. And if I'm going to do work that is beyond a certain standard as a general dentist, then I will not stand a chance. So the knowledge in this course, and I worked on this course with Dr. Simon, me from the perspective of a general dentist and him from the perspective of a specialist, is a game changer, because you have the mind of someone who's struggling, not having went to a specialty school, however, wanting to grow in extractions and wanting to do them at a high level. And then you have another guy who has 20 plus years, double boarded, operates at a high level, extracts the teeth of, some of the top, most demanding people in the world, and it's handed to you and me on a golden platter. So, yeah, it's really exciting, and it is my duty to scream from the top of the mountain that this course is incredible for any GP, general dentist, who is extracting teeth in his practice, because it's going to really help you build value for what you do, because we do great things, but a lot of times we don't know how to position ourselves. We don't know the value of what we do. And if you can see a Beverly Hills specialist, and not just that, a specialist that is well regarded in the community, well loved, well respected, and he is sharing openly with you his tactics. It's a no-brainer. So thank you, Ziv, on behalf of all general dentists around the world for sharing your knowledge, because I believe you're creating a legacy here. You're not letting that knowledge die off with you. And what's also more important, and I saw how Ziv took the time to create this. Look, it takes sacrifice away from our families. That costs something. That's, family is most important in this world. And when we take time away from practice, from family, to create education that is really needle moving, thank you for doing that. And thank you for the sacrifice, because I saw how hard you worked on this. I know how many hours and nights you put into this. And try it for yourself. Get the course. The price is going to be covered by your first 2 or 3 extractions, or even 1 extraction, depending on where you practice. But know what a specialist does, so that when you walk into that room, you're not at a handicap. So you already know, oh, if a specialist does it that way, I already do the same thing. Maybe I'm just going to add this one thing and optimize the process. So respect. Thank you. And yeah. What
Thank
is
you,
this?
Roshan.
The recipe
Thank you
book,
for
yeah?
working on it together, creating that recipe book you're seeing right in front of you. We're going to ship it to the doctors that join the zone extraction method. Go to that site. It's extractionprogram.com. How simple is that? And you're seeing it right now, and learn about it and figure out if this is for you. Okay, we don't want doctors that are not interested in extracting and just want to do restorative, and that's okay too. But you have patients in your practice that need extractions. So there's great clarity in that page, the extractionprogram.com or extractionprogram.com, about the course. We want to just be fully transparent of what it includes, how many CE credits you're getting, and the exact tuition. And all of that is summarized very, very nicely in this course. And that tuition is being reduced for a limited time. So I think what we can do now, Rashad, is to review questions.
Sure.
And we still need to talk about, how to charge for an extraction and how much time to allocate.
Yeah. Does access to the course last for a certain amount of time?
What's the question again?
Does access to the course last for a certain amount of time?
Great question. So the access to the course does not expire. It does not expire as long as there's internet and we have that course available. So it's a one-time purchase. What does expire is the monthly coaching. We can't coach you for life for $1,400. It's just not practical, and it's going to limit us in terms of the service that we want to provide. So when you join the course, you have 1 year of monthly coaching with us. So you can go live just like now and speak to us face to face, go on camera. It's a lot of fun, and more than fun, it's very helpful. After 1 year, you decide you want to continue with the coaching, join another course, get another year, or just purchase it separately.
Dr. Judy saying, this is a beautiful program. I wish I had this program that Dr. Simon provides the dental community 35 years ago when I started my dental career. Amen, Dr. Judy. I wish I had it 20 years ago as well, because we kind of practice by ourselves, and when we travel and go to different courses, it's fragmented. There isn't that much follow-up. And we tend to forget things when we get back home because we don't practice it. But with the structure of these courses that Dr. Simon and myself, we're intentional about setting it up in a way where we give you the knowledge base, so you cover your knowledge gaps. And once you have your knowledge gaps covered and you've calibrated your skill set, your knowledge base to what's being presented, then you're like, oh, I know all that. Oh, I missed that. And then you have there's no holes in your ship. And then as you sail and you encounter different cases, then you can bring them to the monthly coaching and mentoring, where as a group, we put our head together And you know, Dr. Simon and myself, we go to bat. We help a lot of doctors prevent a lot of, you know, mistakes had they been practicing by themselves. So we practice together. And me too. Like, I bring cases to Dr. Simon, and just to have a specialist who's not passive aggressive or jealous that you might want to be doing surgery, someone who's genuine about helping you, to me, that's priceless, because you save one headache, just one headache. And if you're a red-blooded dentist, you know what a headache is, whether it's a complication or a problem patient or a mistake that we're all, you know, been exposed to making. If you can save just one, what's that worth to you? So great comment. Thank you for that. Do you sell the forceps instruments that you showed?
So this is how it's gonna work. A lot of dentists are inside that black hole of instruments, and like there's so many instruments, and they're being sold so many things they're not going to use. So we identified the tools that are necessary to execute on the zone extraction method. So when you join the course, you'll have the option to purchase a surgical kit with all the tools that are included inside the course. So yes, you'll be able to purchase them separately. The tuition does not include the instruments, obviously, but there'll be an option to buy them as well. Okay.
Can you explain the side cuts? How deep do you go, etc.?
Great question. So side cuts, and that's explained in very much detail inside the course. Obviously, there are a lot of details there, simple details. The side cuts are meant to create mobility of a root. So typically, I go to the middle third of the root, typically, depending on how long it is, depending on the curvature, but in general, but the middle of the root, typically mesial or distal.
Nice. Is it possible to pay using digital coins? Yes, we accept Bitcoin, Ethereum. If you're interested in that, message our help at surgicalmaster.com.
I'm gonna cut this for a second. We don't have Rashad. Not yet, because it's we don't have that option yet, but we might have it in the future. I don't mean to we're not objecting to it, but we just don't have a clear way to do this at the moment. But we'll probably get there.
Okay. Dr. Mohsen Ali, he said, I missed part of the webinar. Would it be available to watch later somewhere? Lovely presentation, and I need to look at the website looking to sign up. Check out the website, and you're going to get a replay for this webinar soon. Does the course cover grafting at all?
No, the course does not cover grafting. It's a pure extraction course because we don't want to get distracted. We want to have teeth extracted, but not distracted. So the focus of this course is how to remove that tooth, whatever it may be, out of the 32 teeth, every tooth in the mouth, and all the different scenarios. Grafting is for other courses. But when you do a great extraction, you have a greater potential for better grafting, obviously.
Grafting is the easy part, by the way. Anonymous, or management of complications. Again, we focus on the extraction part, but students in there, if you've had complications, you want to discuss certain topics, that's what you can bring to the monthly coaching show. Where do we access the book again?
Okay, so first of all, you have the extraction recipes inside the course itself. So you can download them. Number one, you can laminate them. You can print them out if you want to. But we are going to also send you the actual book in the mail. I mean, as long as you live in I don't know how to put it, like in a place where there's mail, where mail is predictable. It's not true for everywhere in the world. But if you live in the United States, Canada, most countries in Europe, we can send it to you. It's included. Now, there was a question here, and I'm not sure if the doctor is still live with us. If you joined the zone extraction method before, and we opened registration before in December, we're gonna grandfather you into that. So we're sending you the book for no additional cost because we just want you to have it. We want you to be excellent at extractions. Okay.
Awesome. At the link, the price is different from $14.97. We'll check that and we'll get back to you. I'll check that right now, actually. Dr. Sammy's asking if a dry socket develops in a third molar socket where a nerve was exposed, what dressing do we place, especially that eugenol-based medicaments are neurotoxic?
You know, I don't know the biochemistry, but there is a clove-based with eugenol dressing, and I simply, now it comes as a liquid, and I simply take a collagen plug, take that liquid and place it in the socket. I like to irrigate it with some saline, remove all sorts of debris. And most of the management of a dry socket is through medications and patient management and hand holding, because no matter what, a dry socket will take about 2.5 weeks to heal. Sometimes we use PRF in the socket, but in my experience, you know, I keep the patient on in another week of antibiotics and good medication regimens for anti-inflammation. Because what is a dry socket? A dry socket is inflammation, specifically inflammation in the bone or osteitis. And that unfortunately cannot be healed. It can be only managed with that dry socket paste in the way that I shared it.
Okay, great. I checked, doctor, that asked it's at $14.97. If you see anything differently in the link, then let me know. But that's the price that we're launching at this time. Would you mind introducing the appropriate surgical handpiece for general dentist? Dr. Ramina is asking. Appropriate surgical handpiece. What's your thoughts on surgical handpieces, Ziv?
Yeah, my opinion is that it's great to have an electric one. I'm not the most tech savvy about, you know, the exact specifications, although I have an electric handpiece. We don't want to start blowing air under flaps, not to get air emphysemas and discrepitus and, you know, air going into the facial spaces. So an electric handpiece, a contra-angle is quite good. I know oral surgeons are using a straight handpiece, and that's okay too. You know, I have more like I feel like when I'm doing an extraction, I'm doing a dental procedure. So a contra-angle is a very, you know, intuitive tool in my hands.
Do you know why oral surgeons like to use those straight handpieces? What's the benefit of that? Have you noticed maybe less dry socket with a slow speed that the oral surgeons use versus the high speed that other approaches use? Like,
No,
what's the
it is a
wisdom
high
of that?
speed. It is a high speed.
Mhm.
It is a high speed that oral surgeons use, but it's more straight. And to my knowledge, and I could be wrong, but to my knowledge, it doesn't have to do with more or less dry sockets. It's just the convenience because they're reaching all the way in the back. They have to, you'll see it inside the protocols. They have to split teeth. There's not too much access. They have to create windows of bone. They have to expose bone to the CJ. They have to split teeth while they're, let's say, horizontally impacted or mesioangulated or distoangulated. So I think a straight handpiece is easier to reach. And I know I see across the board oral surgeons using it.
Got it. How long do you hold the elevator in one position when trying to gain mobility? Do you hold for a while in one position for 30 seconds or so and then change position or move it back and forth quickly? What's your standard for that?
Okay, so the standard is mobilization with a forceps for about 1 minute, then with an elevator for about 1 more minute, and then go back to the forceps for about 30 seconds to a minute. So we got like 2.5, 3 minutes of mobilization. With the medium straight elevator, I try not to do too much wiggling. I try to apply side pressure on the tooth, on the coronal structure, and leave it in that position. Let those PDL fibers stretch, and then I release it. I put some pressure, and then I release it. And you'll notice if you do it enough, every movement, well, it's going to loosen up more and more.
Okay. Did you answer that question, Ziva, about the side cuts? How deep do you go?
I did. I said middle part of the root. And there was a question I was in the process of answering. It kind of disappeared in the chat. Oh, here it is. I got it. Go ahead, Rashad.
Regarding the Benix device, is there any caution if the adjacent teeth or the broken tooth have fillings or are decayed? Dr. Fatima Karim is asking.
Great question. So the Benex, yes, there is a concern if the adjacent teeth are not strong enough, because you are basically applying a force to remove the tooth vertically, but at the same time you're applying another vertical force on the side forces, but it's a compressive force. We know that a compressive force is not as damaging, but if you're going to apply pressure that is not 100% perpendicular to the tooth, you might break things. So the Benex system comes also with cushioning. You can isolate the tooth with a special tray with some blue mousse inside, and that will protect the adjacent teeth. So there's a way around it as well.
Dr. Arpon and Dr. Karimi are asking, what are you covering your bone grafts with? What's the brand of collagen membrane that you're using?
The collagen membrane that I use, I'm using mostly the Biomed Extend by Zimmer.
Biomed Extend. Our dentist, Dr. Tony's asking, are dentists changing to piezoelectric rather than immediately starting with forceps or elevators? What's the word on the street that you've heard with that?
Well, the word in the industry is you must have a piezo, but I don't use piezo for my own extractions. I have a piezo for sinus lifting, but I don't use it for my own extractions because I don't think it's 100% necessary. I think it's beneficial, but you'll have to set up the piezo. You'll have to use those tips. Each tip is about $100 or $150 for one tip, and you can break them easily. So it's not the most cost-effective thing, but for certain situations, to create those cuts around teeth with a piezo can be more gentle on the extraction, but in the big picture, it's not 100% necessary. Plus, not every dentist can afford to buy a, $6,000, $7,000, $8,000 piezo for teeth. You don't need to invest thousands of dollars. You need to invest in a training, invest in burs, and obviously a surgical kit. You can't extract it with your fingers, but you don't have to buy a piezo, in my opinion.
What is the name of the dry socket liquid that you use?
I don't remember. I call it the brown liquid. It's called the dry socket paste, and I get it from my dental supplier. It used to come with all sorts of fibers that were being placed inside the, I think it was Alvogel, was placed inside the socket.
Alveogel dry socket dressing.
Yeah. And then it switched to a brown paste.
Yeah.
And now it's brown liquid. So the liquid is actually easier because you just put it inside a gel foam or a collagen plug and put in the socket, and it conforms to the socket anyhow.
Dr. Deborah Stewart is asking, what is the cutoff date for registration for the course? She's teaching and she has some issues with timing and all that. Our team are going to send some emails and everything will be outlined in that, Dr. Stewart.
Yeah, a few days. You can still join. No worries. You can do it tomorrow. You can do it probably on the weekend as well. I think up until the weekend or Sunday. But doctors are joining as we speak. So congratulations.
By the way, just the positioning, the ergonomics, knowing, because when you're a GP and you don't do this every day, or you're starting out early, or you don't do too much extractions, even patient positioning is confusing. Like, how do you position the patient properly? Supine, 180 degrees, turn to the left, to the right. So that segment, yes, it's a short segment in the course, but it was a very important segment for me because it gave me clarity. And the book that comes with the course, for every zone, shows you the elevation of the head and how you should position the patient. So it's a great training wheels for anyone who wants to do extractions and do them in a way where you don't do extractions the wrong way for 5 years and then, oh my God, then you learn it. Learn it now. I mean, the price for this course is peanuts compared to the value that you're going to get of just having peace of mind and knowing best protocols on how, a periodontist and an oral surgeon, and they both, by the way, practice in the Beverly Hills area. So you're getting knowledge from people who are highly sought after, and that's a treat. Last time I checked, whenever I was trying to learn from someone who was highly sought after, they were very hard to reach. They were either too busy or they wanted to maintain their competitive advantage over you and myself, and they did not want to share. And they say that flat openly. So for someone to share his knowledge with you for a nominal fee, it's a no-brainer. And the sooner you learn this, the better, because the sooner you learn best practices, the better the implications are on the long-term trajectory of your career. And I'm talking from personal experience here. Doctor is asking, why not use luxators? You use luxators, Ziv. What's your thoughts on how to use luxators? What's the order? What's the thought on that?
Yeah, I mean, luxators are basically a type of elevator that fits in between the tooth and the bone, and you are able to apply gentle forces. So these are the different tweaks. So if you prefer that type of design, you basically would use it instead of the straight elevator. Some people like to use those luxators with a little mallet and tap around the tooth. That's okay too. Patients just don't love that banging, and it's not always necessary. And I don't want to say that the zone extraction method is a solution for every tooth in the mouth. Well, there's some ankylosed teeth. Certain teeth are ankylosed. Well, can't even luxate them. So what the zone extraction method will give you is a system, a method of how to extract teeth with high predictability and for every scenario, so you don't have to reinvent the wheel time and time again.
Yeah, it allows you to compare notes, and to compare notes not just with any Joe Schmo, with Ziv Simon and Brittany Sonicson. So that's cool, you know. A lot of people trust these people. What's your thoughts on the magnetic mallet? Have you had any experience with it?
No, I haven't. I've seen it. So the magnetic mallet, I think it's not so much the magnet, it's like some type of mallet with resonance that vibrates the tooth, but I've never used that. So I can't tell you
I'll
what it
tell
does.
you one thing though, the mallet has saved my butt in a lot of cases where I couldn't get a tooth out. And inside the course, Dr. Sonicson talks about how she uses the mallet in the course of extracting teeth. A lot of times when we break root tips and they have no mobility, and you're trying to dig in there and it's just not moving and there's blood everywhere, well, your savior will be the mallet. If you've experienced that, you know what I'm talking about. Dr. Kareem is asking, Javid, it says on the website that the registration with the 500 discount lasts about 6 days. Is this correct? Yes, that's correct. The current fee for this course, the discounted fee, is part of the promotion that we're running at this time, and there's a cutoff date for that. You can still get it later. You're just going to pay a little more money for it. And by the way, it's still worth it. Okay. Dr. Deborah's asking, any new info on irrigating the socket, curetting socket, and squeezing the socket? Don't squeeze the socket.
Don't squeeze the socket. I want to say, yeah,
squeeze the socket.
that's not a new thing, but it's don't squeeze the socket because there's no point. You want to preserve that buccal plate. I know this is what we were taught in dental school. I went to dental school in the 90s. Squeeze it. No, don't, because we're going to place an implant in there. You want to have that buccal lingual plate, palatal plate, in a non-squeezed way. But irrigation is very important. I mean, I'm big on debridement. And even the patients are actually now more educated, and they're asking you, will you debride the PDL? Patients get educated. Well, of course, I debride the socket. That goes without saying. I irrigate it with saline, depending on the level of infection, and also PRF liquid.
Cool. And Zeeb, why don't squeeze the socket? Like, as a public service announcement, whether you sign up for this course or not, you know, what's like when you squeeze the socket, you lose two key elements. Can we just make it clear for everyone on this call right here? What are you losing when you just squeeze the socket?
You're losing volume.
Volume of
You're
bone.
losing volume of the bone. You're
Mhm.
creating unnecessary trauma. Plus, you're doing something that has no meaning. It has no meaning, and we don't want to do things without a meaning. The socket will heal secondarily, so you don't need to advance tissue. You don't have to squeeze the bone. It will just fill in with bone graft material, with your blood clot, with maybe a couple layers of collagen plug or PRF plugs. You suture it nicely, and it will heal with keratinized tissue.
Yeah, I mean, in dental school, yeah, they taught us to squeeze that socket, but you're gonna lose attached gingiva. Why? Because you're going for primary closure. Don't go for primary closure. You're gonna lose that beautiful, thick tissue that's gonna be the savior of your implant later on. So, and the bone. Thanks for taking the time to putting this together with systems and steps for each tooth and for making it simple. Dr. Deborah is saying, well, Dr. Deborah, it takes an educator to know what this educator did, because you know very well the level of intricacy and detail that good education takes. And thank you for your vote of confidence, because you obviously know what it took to do this, because you're an educator yourself. And she goes on to say, wish they would do this for students in dental schools. I wish so too. We'd love to collaborate with dental schools to really spread that knowledge, and we hope that uh, that can be a reality in the near future. All right. I will be signing up tomorrow. I have some issues. No worries. If you have issues with your card, like Dr. Simon said, till Sunday. Dr. Fatima saying, Zeev, you are like a compassionate parent who takes the kid's hand, shows and helps to how to walk, and finally makes the kid independent comfortably. Big thanks. That's exactly what Zeev is. And he happens to be skilled at what he does.
Thank you.
Yeah. Uh, okay, what else here? Thank you for sharing your knowledge with another great lecture from the expert and the best. And what a good introductory course. Yes, Dr. Aguilon, I can't agree with you more. And, it feels like it's our duty to market the shit out of this course, because it is such a low-hanging fruit for all dentists that why continue doing bad habits, or why go into extractions with a lack of with uncertainty or a lack of confidence? It is not that hard. I'm a GP myself. I learned this stuff. Monkey see, monkey do, and monkey get good results like other monkeys do. It's a really it's a great course, and it's laid out in a very simple way. And once you get through it, you're gonna notice that you're gonna develop a new operating system, a new thought process with a lot more clarity on the sequence of events that need to take place during your extractions, the instruments and the sequence they are to be used in, the burs to use, the post-operative instructions to use. So all these things, yes, we all do them, but let's face it, we do them at different levels. We're not all created equal. Now, when someone like Dr. Simon comes and standardizes this, why not work on the high standards? Ultimately, you'll have more success. You'll have the courage to charge more. Why? Because you're adding more value with less complications, less ridge destruction, more clarity in how you're doing, better management. Plus, one thing that I benefited a lot from Zeev is the thought process and how you present yourself, how you show up when you meet patients. Depending on how you talk, people are either going to value what you do or they're going to discount what you do. So the way you talk, the way you reason through things, the way you carry yourself chairside will either build value or it will say dentistry is expensive. And even if you say the extraction is $120, they'll be like, oh, 120, do it for 90. Come on. So learn how this guy does it. And he doesn't charge cheap for his extractions. He doesn't charge cheap. We're not going to price fix for what Dr. Simon charges, He doesn't charge cheap. And yet he's booked months ahead. Why? Well, take the course with him. See how this man thinks. It impacted my practice. It took me from being an HMO, PPO dentist practicing in 60 different offices to opening up in Beverly Hills, where I wasn't born here. I don't have connections here. And the only thing that could get me ahead is my bedside manner and my skills. And the skills that you'll be learning in this course are the same extraction skills that I use in my practice and that have helped me build my practice and my bottom line in a very competitive environment. So, yeah.
Amazing.
Yeah.
Should we
What
answer
else?
some questions? Some good questions here.
Shoot.
Can you please show premolar cases too? Thank you. Sure. There's a lot of premolars break like that. They snap. Those upper premolars, they just snap in half. Yeah, in the course, there's premolars. It's about the system. You need to know the anatomy of an upper premolar with the furcation, with the the buccal and palatal roots, know where to split, etc. So this is a great question. There was a doctor who asked about, can you show the forceps again? We're going to send a replay of this webinar shortly.
For orthodontic treatment extractions, how do you do mobility when the teeth around are also mobile? Does the course include anything like it? Great question, Zeev. You get these premolar cases, they're stuck. You need to extract. By the way, please don't extract premolars for orthodontic cases. You're going to collapse the jaw. Make sure you question the orthodontist about that. Expand the jaw. You'll help with the airway. You'll impact the patient for the rest of their life. If you're extracting teeth routinely for your orthodontic patients, don't do it. Okay, because it's not good. Maybe some cases, but most of the time there's other ways. But with teeth with super close proximities, Eve, how do you luxate without mobilizing the heck out of the adjacent tooth?
Right. No, these are true questions. So look, we don't want to create damage, but somehow that mobility is going to help us. So I would probably for the young patients, if you need to extract a premolar, well, they're not going to be well grounded. They're not going to be as well rooted as an adult with the same tooth, already been in the jaw for 30 years. So I would typically use forceps, and I would have a good grab. I would separate the soft tissue, and I would start with just patiently rotational movements around the axis of the tooth. And there's going to be a give. And once I have a give, then I can use a small straight elevator. And it's even easy or simple to extract with a periostal elevator, with like a Selden elevator. But look, if you don't have if a tooth has a path of exit, it can be extracted atraumatically. If it's stuck underneath the crown of another tooth, that's a different story. So you might need to section, etc. But it's pretty rare for these cases. But in all transparency, I don't think I'm doing. I mean, I don't do a whole lot of orthodontic extractions. Like Rashad said, things have changed, at least where we practice. It's pretty rare, maybe once a year. So I don't really see this often, but I see tons more, day-to-day procedures. So if your question is, will this course help you with these types of extractions? No doubt about it, because you'll learn about how to extract the tooth. And that's typically scenario A, where you have the full crown and you're going to follow the A recipe.
Do you do any lectures like tonight's at any dental meetings? Would love to turn your name into several meetings to get you to do this course there. Yeah,
I do sometimes.
Yeah.
Not so much anymore.
Yeah. Help us spread our message. It's more than just selling a course and generating income for a business. What we do is a humanitarian mission to really revolutionize dentistry because,
Dentistatarian.
huh?
Dentistatarian.
It's a dentistitarian mission. So, it's enjoyable to share knowledge and to collectively grow as a group because we're pretty isolated as dentists and we're hoarders as well. And we don't share with each other and we're jealous from each other and we tend to be greedy. So it's really refreshing to be part of a community of like-minded dentists that believe in collective growth. Because let's face it, the patient that wants to see you doesn't necessarily want to see me, and the patient that wants to see me doesn't necessarily want to see Dr. Simon, and vice versa. I mean, our patients, there's a cosmic spiritual element to the patients we attract. And if we can collectively help each other grow, why not? I mean, we're not going to get uber rich from dentistry. We'll live a great life, but it's really nice to have systems and standards that will elevate the entire profession because there's a lot of mistrust. I treat a lot of patients who have been traumatized by extractions. They come to me from all over the US and the world because they're traumatized. Why? Because I don't know if you were at this webinar when it first started, you saw that man just put a forceps and yank a tooth out of a poor kid's head. Now he was probably doing him a service because he was in pain, but there's a better way to do things. There's a more elevated way to do things. There is higher standards to do things. And what better place to find these standards than in Beverly Hills, California, from a Beverly Hills specialist who is well respected in his community, who gets referred to by a lot of dentists, including me, many dentists on the floor where I work and in my building. I mean, Zeev is a gem of a guy. And anyone who knows him, anyone who's worked with him, he's not a specialist that throws GPs under the bus. He's a guy who works as a team with you, and he's very generous with his knowledge. So thanks for sharing your knowledge, and another great lecture from the expert and the best. What a good introductory course. We mentioned that. Dr. Benji is saying that's how they used to extract teeth beforehand, pieces with mallets and chisels. Yeah, it's kind of fun, Dr. Benji, to use a mallet and a chisel because it feels so good when that root tip comes out and you've been trying to get it out for a while. But there's also a different way where Dr. Simon goes in the protocols on how you remove bone with these cases as well. So a mallet and chisel, it needs a set of courage and knowing what you're doing to do it that way. I don't know, Zeev, do you ever use a mallet and a chisel, or is that something reserved for many oral surgeons and some GPs like myself?
No, I don't. Honestly, I don't. I use a mallet for sinus lifting, really, but my partner just uses it all the time. It's
Okay.
probably a good thing. It's probably a good thing. And here's my message. If you're using a mallet and you're using special periotomes that you tap in and you do the tapping, and that system works for you, awesome. Keep doing it. But if it doesn't work for you, or you feel the lack of confidence, and you feel that your root tips are breaking all the time, and you're feeling frustrated, and you're sweating, and you're running behind, and you're just trying to survive and doing what you need to do and destroying the buccal plate, well, take a timeout. Educate yourself about protocols, learn the recipes, and I guarantee that if you follow that system, you're going to be better compared to where you were at before. There's no doubt about it. It's like it's not even a question. And there's something to say about people that fly planes and people that build bridges and architects that design skyscrapers. They're not going to wing it. They're not going to just show up and like, you know what? Let's build the first floor. Now build the second floor. Now let's see how high this high-rise can be. It just doesn't work like this. You plan the whole thing start to finish from the ground up. You figure out the foundation. You figure out the light switches and where the restrooms are going to be. Because if you forget to put like a couple of water pipes, well, the people upstairs are not going to have enough water pressure for their restrooms. So that's what the zone extraction method is. It's really a pilot's, engineer, architect, doctor, surgeon approach to doing extractions. Bottom line.
It's not jumping around. Like Ziv said at the beginning, no more reaching out for random tools when extracting teeth. No more like, oh, what's happening? It's breaking and you're sweating and your assistant is not retracting in the right area and you're like suction here, suction there, and you're like taking x-ray now. No, it's not a reactive approach. It's an intentional approach to extractions. It's just as intentional as when you go to do a class 1 filling. You use whatever burr you use to eliminate the decay, and then use your slow speed if you need to, and then you bevel the edge, then you etch hopefully just the enamel, then you use prime and bond on the dentin, then you layer your composite, and then if you want, you can do some characterization. It's predictable, it's step by step. Whereas extractions, historically and up until this moment that this course has came into existence, have been put that forceps on that tooth for the majority and pull, elevate here and there. No, that's not intentional. It's tactical, like Ziv said. It's planned. So you go into it with intention, knowing what's going to break, where it's going to break, what are you going to do so it doesn't break. So it gives you confidence. And what does that translate into? You're like, oh, wow, I can't believe I've been putting my patients through this for the past 10 years. There's a better way. And then what does that translate into? You know what? Because I'm taking my time now and I know that I need to book an hour and a half for my extraction, I'm going to charge more. And you know what? Because I'm not going to hurt the patient, I'm going to make sure they're numb because I'm going to follow up some numbing protocols that I learned in this course. I'm going to give the patient an hour and a half of my time. And for that, I'm going to build my reputation as a doctor who does not hurt people, does not traumatize them, and extracts teeth in a way that preserves the ridges. And as a result, my friend, you're going to make more money, and you're going to make more money doing the right thing at a high standard. And you know what's going to happen to your competition? They're going to be left in the dust because they're practicing in a different way. So take the Beverly Hills standard, implement it wherever you're practicing, let it elevate your practice and how you're practicing, because, you know I keep repeating myself, but it's my duty. It helped me and it will help you. Ziv, any other thoughts here?
No, many thoughts, but let's review those questions.
All right. Does the course cover scenarios of ankylosed teeth?
So no, it doesn't, because there's not one common scenario that we could standardize for an ankylosed tooth, because an ankylosed tooth technically acts as an implant where you have to really break that ankylosis. But my advice to you is forget about removing ankylosed teeth. Why are you removing them? Let them be. Let them integrate with the bone. Let the bone resorb them and replace them. Now, sometimes you have an ankylosed tooth that needs to be removed, but I find that the knee-jerk reaction of, hey, the tooth is ankylosed, has resorption, it's bye-bye. Don't do that. Well, let's figure out what's going to be the chance of removing it and being able to replace the tooth with an implant. So often we repair teeth that are ankylosed and have some resorption, and sometimes we leave them for root retention, especially in the aesthetic zone.
Clear. Okay, let's see what else. Sorry, join the session. Can you please give me more info about joining the course? Is there a deadline to join it? Yes, Dr. Indu. For this promotion, the deadline, I believe, is going to be this Sunday. Check out extractionprogram.com, read through it, and you're going to get a replay. So watch the replay. If this resonates, if the way Ziv is teaching resonates with you, then join it. If not, then benefit from this free education, and we wish you the best. Either way, we love you. Thank you for another amazing free course. 6 years ago, I did pick up on a free ebook and CE on money tooth and gained courage to do many extractions. Well, doctor, if that's the quality of the knowledge you're getting in our free education, then imagine the level of dedication we have for you when you join our paid programs. Because when you show up and you invest in surgical master and yourself, rest assured that we've got your back. Dust it down when not able to get it out, and help me no matter what, I will get it out. Thanks again. You are the best. Thank you for this vote of confidence. And we love working and sharing knowledge with great-hearted dentists like yourself. What else? What else, Zeev? Do you see any questions that I might have missed?
Yeah. So I'm looking at the Q&A. So what about those devices that anchor into the broken roots and pull them out? So that device, one of the devices is called the Benix system. And we have the protocol for that as well included in the course. And of course, you'll have to buy that device, which I strongly recommend. If you're involved with extractions, it's a must-have. This morning, Rashad, I shared with you this case of a person, a patient, who is quite well known. But let's put it this way.
He's very well known.
Probably a few billion people know this person, would you say? Especially people who like to watch television.
At least.
Not gonna say, and that's not the point, actually.
Yeah, but yeah.
It could be stressful to get into that situation with that person where they have a tooth broken down below the gum and like, I don't want to struggle here. I want to go in and out. I use that vertical extraction technique. Literally took 10, 15 minutes. It was done, including the bone grafting. And that really, I went into it with confidence, not knowing if the Benix is going to work 100%. Doesn't always work because the tooth can be broken or decayed and that anchor doesn't work, but it was flawless. And it's just a great thing to have.
Love it. And very important, you're going to share that. It's part of the bonuses, right? Where you talk about extractions in the aesthetic zone and how to manage that. And
actually it's inside the course. So we're it's part of the course.
Okay, great. Another thing is the bonus on implant removal. That's huge. And there's like a case, a full mouth implant removal case you'll be sharing. It's a case I did. You helped me with it. And I'm sure you have tons of cases that you're going to be sharing for that as well. Any other questions, Zeev?
Let's see. Is the one for full mouth for dentures? So the system to extract one tooth, and let's say you have a tooth next door that needs to be extracted, the system might be different. The recipe might be different, but you can apply it to a full mouth, if I'm understanding the question correctly. There is something that we promised as well. How much time to schedule for an extraction? I can tell you right now, it's not 15 minutes. I've seen courses, and I'm not going to mention the name of the educator because I respect. But the recommendation in that course was to schedule an extraction every 15 minutes, a wisdom tooth extraction, like 15, 15, 15, because it takes 2 minutes to extract a tooth. That's not the type of surgery I want you to be involved in. First of all, speeding things up will cause complications, and let's call them stupid mistakes because you're rushing. It's like I tell my kids, when you're doing your math test, and I'm not like a genius or anything, I'm pretty normal. But when you do your math test and you do your calculation, your multiplications, write the answer, double check that, because the next step is based on the previous one. And if you messed up the first one, everything will trickle down to the final answer, which will be wrong. So 5 times 7, well, make sure you wrote down 35 and not 45 by mistake, because sometimes we rush. Same thing with extractions. So how much time to schedule? Categorically, an extraction typically is not just an extraction in this world. It's usually an extraction, bone graft, preparation for an implant. So let's say that thing takes me half an hour, 45 minutes, depending on the difficulty. I'm not going to book 45 minutes. I book 1 extra hour. Now, it sounds like, whoa, that's chair time. And by the way, I'm not saying this is what you need to do. I'm sharing what I do. Even if it takes me 45 minutes, proper procedure time. Why? What happens to the timeout protocol? The local anesthesia to take effect, minimum 15 minutes. Minimum, sometimes 20 minutes. For the laughing gas, for the sedation to take effect. to work without rush, to recover the patient, to go over post-op instructions. We miss out on this thing to get the family member waiting outside, or the friend or the spouse. Come in. That's implicit marketing. You get the person that never even had the surgery in the room to listen to the extraction, and they're sitting there and like, whoa, this is like somebody I want to, if I needed an extraction, I'm going to see this, or I'm going to recommend them. I always do it without exception. Like somebody's like, bring the patient down. I'm like, no, 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 no. Please park the car, validate your car, valet your car, come upstairs. We don't want to rush anything. I want you to know you're giving it gravitas. You're giving it value. I spent like 15 minutes. Can I rush those instructions in 15 seconds? Or just giving the instructions and on to the next? You can do that. But that's not how you build the practice. I know everybody says that, but very few people do that. You don't have to say I'm the best. You want your actions to show, dude, this is a pro. This is a pro in what he or she does. This is a trustworthy doctor. This is worth what I'm spending here. We're going to teach this, Rashad, as part of the Beverly Hills Standard. That's going to be part of our training, like how to position yourself as the best to treat, as the best doctor in Beverly Hills. That's the Beverly Hills standard. No matter where you practice, you can have that standard. And it's not rocket science. It's like that 15 minutes brought me so much business that I can't even handle. I had to hire another doctor to handle that business. And not because I'm very smart business-wise. I'm not. Okay, I'm not. I learned from mistakes, and I learned because I'm old what not to do. But back to extractions, back to that topic here, book an extra hour. You'll never know when you're going to need it. And that hour time is time well spent. If you're going to book patients on the minute, it's not sustainable, because we know shit happens. You're gonna break that root tip. You're gonna break that upper premolar root tip, and you're gonna spend an extra 15, 20 minutes fishing for it. You need to take another x-ray. You might need to take a CT scan. You might break the buccal plate. Oops, it happens. You might have to use a membrane to recover that. So you need the time. So that's time allocation. So I would say for a low molar extraction bone graft, I book 2 hours. I know it sounds like a lot. I actually use up 1 hour, but book at least an hour and a half. If you're seeing a tooth that is like class 3 mobility or a loose implant, well, I don't need more than half an hour, but I'll still book the 45 minutes. Now, fee schedule. That depends. Do you want to do volume, or do you want to do less volume and charge more? So let's first of all start from the outside in. We don't want to do volume. We don't want to do volume. I don't want to do volume because my back and neck do hurt, even if I use Ergonomics. So my goal in my practice is to do procedures. 80% of my procedures, I want them to be simple with the least effort. And I don't want to do like 10 a day. I want to do 2 a day. 3 a day max. The rest is consultations and follow-ups and reevaluations. So my goal in my practice is to create a schedule, and that's also the Beverly Hills Standard. I create a schedule that has slots for surgeries, for consults, and for follow-ups. It's not that the patient calls and we tell them, okay, when do you want to come in? Monday, Tuesday, Wednesday, Thursday, Friday. When do you want? No. We have a slot for surgery on Friday morning. It's currently taken, but sometimes people cancel, but we'll put you in a waiting list. Okay? Don't give up all your schedule. So the fee is also appropriate for a doctor that doesn't want to do a lot of procedures, because I have an expiration. You do too. The more procedures I do, the sooner I'm going to expire. It's like the car. the more you're going to drive, the mileage adds up. Well, the car doesn't drive anymore after 100,000 miles. I'm talking the best cars in the world. Maybe a Toyota can drive 500,000 miles. And it's a great car. And I drove a Toyota when I just started. But even a great car now, after 100,000 miles, it doesn't work. And that's your body. And you can't just bring it to the shop because it's not worth it actually for a car. So high fees, less procedures. I prefer to do 2 extractions versus 4 for half the price. So of course we can't tell you how much to charge, but my advice to you is look at what people charge in the environment. By the way, Rashad, the ADA no longer publishes the survey. It's done. As of last year, that was the last year. Remember, we were teaching how to charge by looking at that ADA survey. So I'm glad we included it in one of the courses or 2 of the courses. It's there, but you cannot find it anymore. At least it gave us an idea. So I think that information is going to stay valid for like 5 years. But the best thing is to do your own intelligence and figure out what do people charge and be at that level.
Ziv, is it, one thing I want to tell everyone here, you might be thinking, dude, this guy is crazy. What does he mean book an hour and a half for an extraction? Maybe you're right. Maybe it's a foreign thought process to you, because maybe you practice in a place where you need to see 20 patients a day and it's just like a mill. And respect to you for doing that. I did that for many years and I hated myself.
Sometimes you don't have an option, Rashad. Sometimes you're not the owner.
I didn't have an option.
You have no option. You do what you need
option.
to do, and you need to do everything. And I've done many things in my life and still do, because I need to achieve something. I need to, make sure that my goals are met. I need to have a certain, production level per month to sustain. Well, if I'm not going to do it, then I need to do what I need to do. And I think that's what you're talking about. So don't feel bad. Nobody feel bad if they're like, oh, I'm doing like 5 procedures a day. I'm rushing. Well, sometimes you need to do, but ideally, identify what this does to you and find a way out of it. Those mills are not for dentists like you.
Yeah, and if that's you, you know yourself, because you'd be practicing, you're unhappy about it because you have a certain type of heart and empathy that doesn't match the way you're practicing. And if that's you, I'm here to tell you that I was in your shoes not that long ago. And I felt very shitty about being a dentist because I practiced in a certain way that had to, like Ziv said, meet goals and production, and does insurance cover, and what narrative do I have to write, and how do I jump through hoops to get paid? Well, that's the majority of the market. That's where DSOs thrive. That's where strip mall dentistry is. And there are a lot of dentists who have made tens of millions of dollars doing that type of dentistry. But I'm not talking just about money here. I'm talking about how much we enjoy our profession, how fulfilled we are at the end of the day, how we feel the quality of our work is. Now, if what I'm saying is resonating with you, if you're understanding what I'm saying, this course is a must. Actually, any course in Surgical Master is a must, because the way Ziv taught me and the way I practice and the way now I am sharing my knowledge is in a way that builds value in delivering slow, quality-focused, patient-by-patient dentistry, because the majority of the market is volume. And if you want to follow and compete on price, good luck, my friend. However, there is a niche, and there is no shortage of money in this world. There are people dropping $3,000 on one night in a hotel. There are people dropping $30,000 on a piece of shit bag, all right, that they carry. There are people dropping insane amounts of money on things they don't need, all right? Now, if you position yourself as someone who can deliver quality care, are genuine about how you present yourself, you are positioning yourself to reap the benefits of a great market and fulfill a non-traumatic approach to dentistry that's focused on quality, not quantity. And good luck trying to learn this from a successful surgeon. I tried. They don't want you to know that. It's not that hard. You probably do half of that stuff already, but they don't want you to know that. Why? They want a monopoly on the market. So this course, the thought process that Zeev teaches, is very powerful. And I can't talk enough about it because it's changed my life. So I feel with any dentist out there that might be feeling bad about being a dentist, feeling bad about the volume approach to dentistry. There is a better way. And the better way is to rub shoulders with people who do it at a high level. Now, if you know these people already, great, pick their brains. If you don't, this is an invitation for you to join this course so that you can start seeing how the Beverly Hills standard of doing extraction pans out. Because you don't need to be in Beverly Hills. You can be in Mumbai, India. And I've been to Mumbai, India. There is a lot of wealth there. If you deliver in Mumbai, India, a certain level of care, oh, I went to a wedding in Mumbai, India. The budget for the wedding for 3 days was $4 million. You heard me right. So there is wealth in this world wherever you are. If you are someone who feels like you want to deliver that quality of care, regardless where you're at in the world, get exposed to it. Join the course, extractionprogram.com. And I'd love to meet you because people who think like that are interesting.
Thank you, Stephanie. Great content. Thank you for presenting a very thoughtful, systematic approach to managing and treating extraction cases. Thank you. Definitely looking forward to implementing into practice. Awesome. Look, I looked through my, when I built this presentation, I looked through my portfolio. There's so much out there, and it's very easy for an educator or educators like Rashad and myself, like, take what I have, just throw them on slides and just go, okay, yeah, we can do that. But we didn't do it because that's the lazy way out. So we decided to systematize what we're teaching and present it in a way that it's simple, short, concise, because why waste time if you can get just the bottom line in the final recipe? This is our approach.
Zeev, do you see my screen?
Yeah, go for it. I see also your background. So if you can,
here, I'll just my screen
do full
just in
screen if
case I have
possible.
any personal things open that I don't
No
want.
problem. No, you just saw the video, I guess the video or the photo.
This is like really cool what I want to share, and it's something that I encountered once, and I was alone. And I think everyone who's still watching here deserves maybe an insight into this, because you might experience it in your practice, and it's good to kind of know what that is, because it's shocking initially when you see it. Zeev, can you talk a little about the liver clot? Have you
Yeah.
experienced
So liver clot has nothing to do with the liver, but what it is basically something that happens following a surgery. And you have an example, so I don't have to pull out mine. And it's basically the patient is calling you after a day or 2 days or the next day, like, oh my God, I have this, like I'm bleeding. I have so much blood in my mouth. And like, okay, give me some details. And like, no, I see this red mass on my tooth, and it's kind of jelly. And then I take it off and I rinse it out and it starts again, and more gel form. So why does it happen? What is it? It's a phase of clotting that is gelatinous, which is gelatin, or feels like gelatin. And this happens because of a slow flow of blood. And some people are more prone to that. So first of all, when you're finishing a surgery, extraction, or any other surgery, make sure the patient is leaving with no bleeding. The bleeding has subsided. If there is that gelatinous structure, that means that there was a slow flow of blood. It's not hemorrhaging, it's oozing. And the blood starts to clot as it starts to trickle down. And then it creates that jelly. So first of all, aesthetically, we can't walk around like vampires. So you'll instruct the patient to take a moist gauze, wipe this thing off, not to worry, and take a fresh gauze and put pressure on to stop that bleeding for about 20 minutes. And that's what they'll do every time they develop that clot. Trust me, after a day or two, no more clots. Some people are just prone to that.
Yeah, the first time, Zeev, I saw that, patient took a tooth out, patient goes home. They're like, they call us, they're like, oh my God, something is wrong. I have this big piece of meat hanging out of my mouth. And it was a lot bigger than this. It's called the liver clot. Patient comes in, I look, and it was frankly scary because it was the first time I ever see a liver clot. And the patient keeps touching it and it keeps clotting and they're scared. So yeah, I just numb them up again, remove it, stop the bleeding, make sure it stops. And there are some patients who are more prone to it. And Zeev just shed light on something, the way they bleed, I assume, or the way they clot. But if you encounter a case like that, don't be scared. Just make sure they're numb and comfortable. Suction all that blood out. Sometimes they're so scared, they're not touching their mouth, and it's just clotting and getting bigger and bigger. So liver clot, public service announcement here to help save you some gray hairs because it can be quite scary. I just wanted to share that, Zeev.
Wait, no, thank you for that. No, this is common. This is very, very common. Awesome. So I think we should just find out if there are any more questions. Repeat what we're going to be sharing at the zone extraction method, which is right here. And then this is the core. I'm so excited about this training, the explant system, how to remove implants. And yeah, it actually became a business on its own. You actually charge more to remove an implant than remove a tooth, or place the implant rather.
Yeah.
It's interesting because it's more challenging. There's a lot of things that can happen, and you need to have a system. So I call it the explant system. Okay, very good. So first of all, whoever attended this training today, we had hundreds, and we have thousands registered, but we had hundreds and hundreds of doctors. We'll get the stats tomorrow, who joined the training today. So first of all, regardless if you joined the zone extraction method today, I hope you benefited from the training and that we added value to you and that you picked up one or two tricks or pieces of knowledge that would make you a better doctor and serve your patients and be more successful, make more money, and enjoy the work that you're doing every day. For the doctors that want to take that knowledge from the webinar today and bring it to the next level and start implementing systems to extract teeth with confidence, with predictability, with elegance, and also in a way that is effective. We don't futz around an extraction. You just get to the bottom line, which is the pulling of the tooth. Then we have the zone extraction method, which is a course that gives you that recipe. So the zone extraction method has all the recipes for all the scenarios in the mouth. You're getting the book itself. It will be shipped to you. You'll be able to join a monthly coaching, getting the presentation on or the training on how to do case presentation, the implant removal system, and great value, close to $8,000. You can join for a fraction. So the ROI on this course is tremendous. Extractionprogram.com. Read about the course, see the testimonials, look at the small details of what this course includes, the number of CE credits, 18, the return policy, very simple. Like, take it, get the knowledge. If didn't work for you, you decided not to do extractions, then let us know. And we have two payment plans. One pay, which is a little bit more economical, I would say, if you do the math, but for 10% more, if it's better for your cash flow, or you just want to just start with that just to be safe, totally fine. We'll ship this to you as long as you give us a valid address and it's not in Timbuktu, although there are probably dentists there as well. It needs to be a predictable postal system. We have experienced in the past, I want to say that we've been shipping things since the past 10 years. It's easy to ship in the United States, to Canada, and to Australia, and to certain countries in Europe, Middle East, where I'm from, Rashad, you as well, is not that predictable sometimes, but we will
Oh,
ship. We won't deliver it personally, although I'd like to, but just give us a valid address. And yeah, looking forward to giving you those recipes, put them in your hands, literally, and more than that, use them to do great extractions.
thank you, Ziv. I want to read a cool comment by Dr. Alex. I personally regained my love for dentistry as a result of following your courses. Thank you for your combined wisdom, knowledge, and insights. Thank you, Alex. That warms our heart to know that there are doctors out there who find value in what we're doing. And Dr. Karimi says, congrats to you, Ziv and Rashad, because your website is not accessible. It says this website can't be reached. I can't register for the course, and I will try again later. Thank
Okay.
you, Dr. Fatma. Always good to see you in our courses.
Yeah, no, Dr. Karimi, I think Arazu is your first name. No problem. We'll reach out to you directly and send you that link. I just privately sent you the link, and I just tested that website and it works. But sometimes a browser can block a certain website for some reason. Okay, who knows? Maybe that browser doesn't want you to know how to do extractions in a professional way. I don't know. It's a mean browser.
In browser.
Okay.
Thank you, Ziv. On behalf of all dentists, love you. Thanks for really helping me up my game. Thanks you for helping me see that there's a way to do dentistry in a very quality way, get paid for it well, and really enjoy it and find great gratification because that's not easily accessible. And there's a lot of noise in the market. There's a lot of ha-ha, rura, salesy, pitchy, sell, sell, sell. What I realize is you don't need to sell shit. There's so much pathology out there. If you focus on identifying that pathology, presenting it with clarity, and executing it with a high level of professionalism without hurting the patient and with transparency, you can charge whatever you want because you're going to be rare. So keep that in mind. And thanks to everyone for showing up, for participating, and we'll see you in future trainings.
Thank you all. Take care, Rasha. Talk to you soon. Bye,
Bye.
guys. See you soon.